A very good day once again, my dear postgraduate students. Welcome to the second class on bone marrow aspiration. Please do appreciate the wonderful picture in the back. I would like you people to kindly explain the needles on the screen because you as faculty will have to do this for your students. On the screen, I am seeing two short, stout needles with stillet. 3S you people remember. The needles are short and stout and sturdy. So look at this picture over here. It is in the form of a wedge. It can cut through. And the stillet is a structure that is kept inside the needle so that it creates a rounded tip. And when the needle enters any structure, there is no damage to the skin or the subcutaneous tissue and only to the bone. This is a principle for any of the needles, be it a lumbar puncture needle or a biopsy needle, etc. Now the Klima needle is short and stout, and after the aspirate, there will be the attachment of the syringe. That I shall explain later. In this needle, I am finding that there is a lateral adjustable screw, which is called a lateral adjustable guard, the Salas needle. So this is supposed to prevent over penetration. For example, in an obese patient and a young child, the thickness of the manubrium will be different. Therefore, over penetration, damage to the underlying structures is prevented. After we do the aspirate, as I had mentioned earlier also, you find that the excess of blood will have to be removed by another needle and syringe. And what is remaining with, you can make a squash of it using another slide. Or again, just like a peripheral smear, a smear can be made and ultimately it is stained. Look at this one. What we are interested in is in the dark blue, the marrow particles and the cell trails. So these are the steps. You'll have to express the aspirate onto a slide, siphon off the excess blood. Whether it is a squash or a smear, you'll have to do it accordingly. And the marrow particles, cell trails are caught hold of, and you will have to examine them after the staining. Bone marrow biopsy. We had mentioned bone marrow aspirations, absolute indications. Biopsy is indicated in certain conditions. Wherever there is a pattern, it is almost like histology, whereas bone marrow aspiration is cytology. For example, in metastasis, an adenocarcinoma, squamous cell carcinoma, adenoid cystic carcinoma, all can be picked up by means of a biopsy. The pattern, it matters. Myelofibrosis, you don't get anything, and you find that it is full of only reticulin fibers which can be stained. Storage disorders such as the Gaucher's, etc., where you find large cells which are foamy or having a, say, a silk-like chromatin, whatever it is. Lymphoma, there can be a pleomorphic population along with the Reed-Sternberg cells. All these are probable, for which you need a bone marrow biopsy. Again, to study the iron stores, etc., it can be done. Now, this is the difference between the aspiration, cell block, and biopsy. Advantage. Aspiration, you can go in multiple directions and do the aspirate. Whereas a biopsy will be a single, like a needle biopsy, obviously. But then you can study the pattern, markers can be used, special stains can be done, multiple sections, obviously. Here also, the cell block, the same thing. You spin it and create something like a tissue, but no pattern will be there in it. Advantage of an aspirate is you can appreciate the cellular morphology much better than these things. And iron stores, etc., can be studied. Disadvantages, sometimes I'll get a dry tap or there can be a dilution with the peripheral blood. In such cases, obviously, a biopsy can be a supplement. But the disadvantage of the biopsy is the target may be missed and it may not be representative. And in a cell block, the cellular morphology is not very clear. Aspiration, if it is not satisfactory, it can be repeated. But here you have got material, so with sections, probably your luck is different. Rapid diagnosis. It is not justified in any of the three. A bone marrow is not indicated for a rapid diagnosis. Whatever be the pressure, just refrain from giving a rapid diagnosis. Assessing the cellularity. On the screen, you are seeing something. Probably these are trails from a good particle. I am able to see a lot of cells. I am not going to go into the morphology. How do you assess the cellularity? The idea is very simple. You minus the patient's age from 100. So if you are going to be a 20-year-old person, it can be 70 to 80% cellular. And if you are going to be a 50-year-old person, then 50% cellularity is fair enough. And in a newborn child, it has to be almost 100% cellular. So that will be it. Whereas there are some conditions where it can be replaced by fat spaces, and that is the use of an assessment. Moreover, I'll be able to see whether there is a representation of all the three lineages. This looks something like a megakaryocyte to me, and these cells probably they are the normoblasts. And there is a plasma cell over here and some kind of a metamyelocyte. I'll be able to see some, but then it is not adequate. I'll have to keep the cells under the oil. One word of advice. Differential count is the best method of learning bone marrow. Do a differential count, count 500 cells. If you do not know one cell, go to the next. This is a classical method of reporting a bone marrow. Picked up from JIPMA, where I was a senior resident, and I had been passing it on to a lot of generations of students. It is quite useful. Cellularity, whether it is adequate or it is diluted or not represented. Adequate means you find, as I told you, the percentage. Sometimes it is hypocellular or sometimes literally acellular. So cellularity is important. And the remarks can be whether it is diluted with peripheral blood or not. Then erythropoiesis. Always erythropoiesis means I should say whether it is active. And then what is the pattern of erythropoiesis? Is there any dyserythropoiesis, etc. Leukopoiesis similarly. The range of cells that I am seeing. And the ratio also, myeloid erythroid ratio will be there. Normally it is 2.5 to 15 is to 1. So I can say whether there is a reversal in the leukoerythropoietic ratio, etc. Megakaryopoiesis, whether it is active or sometimes I'm finding immature cells, as in the case of an ITP. Lymphocytes and plasma cells. Differential count, count 500 cells. That is the best medicine for you people. Mitotic activity. How many? That is seen. Also, you will have to compare and say whether there is any atypical mitosis that is seen. Abnormal cells. Abnormal cells in the sense, for example, a storage or a metastatic cell. Parasites, rarely we do find in the bone marrow, whether you see them or not. Kala-Azar. Impression ultimately. So it is a cellular marrow. It is showing the normal representation of all the three lineages. Conclusion. Marrow within normal limits. Correlate with your clinical features and the complete hemogram. You say that there is nothing wrong with the patient. So this has to be the pattern. Whatever be the question, see that this pattern is being followed. Again, I had shown you marrow earlier. Now this looks more like a biopsy because I am finding the bony trabeculae over here. But then there is more of this empty fat spaces when compared with the cellularity. So obviously it is a severely hypocellular marrow, or I can call it literally acellular also. Severely hypocellular, and then under the oil immersion, I'll have to do a differential count and see what is over there. And this particular thing we shall be seeing any number of times. Always we people should be knowing the cells that we are seeing. Dear students, I tell you one secret. I learned this when I was in my second year of post-graduation from one professor of medicine, Dr. Sethuram. He is no more. He is a self-trained hematologist. And as he was seeing the slides, I happened to knock into his room and then the teaching started. An amazing teacher. Luckily, he had a teaching microscope with him. Whatever be it, you find whether there is a stem cell, a hematopoietic stem cell, what it leads to, the progenitor. Look, they are all almost like a lymphocyte, not very different from it at all. And this progenitor gives rise to the myeloblast as well as the monoblast. The stem cell can have a different lineage giving rise to the lymphoblast. So this is not affected, whereas these, you find that the monoblast, the myeloblast, etc., they are all being affected. And also, you find that there can be the erythroid series also which come under this saving. So you find that ultimately all are getting affected. And also the megakaryocytes. The same thing you find that there is a megakaryocyte and the platelets. So if there is going to be a defect in this particular stem cell, all will be increased. Patient will not be anemic, WBCs are increased, platelets are increased, and you find basophils are obviously increased in CML. So these are the things. And then there is the erythroid series also. There will be the different ones, whether it is the basophilic or the polychromatic or the orthochromatic erythrocyte ultimately. So these things we'll be having in mind and try to identify them in the bone marrow that we are seeing. I have given you just one series for an explanation. I shall be going into it later. So there is a hemocytoblast and then there is a common myeloid progenitor. We call it a more of a committed stem cell. It can produce only this myeloid lineage, from which I have got the myeloblast, the promyelocyte, myelocyte, metamyelocyte, band form, and then the neutrophil. Initially, it can be agranular, the myeloblast. Then the promyelocyte is also there. It will be having granules. Sometimes the myeloblast can also have granules. But the point is, these are all primary granules. You do not find the color differentiation, eosinophilic, basophilic, neutrophilic. But later on, I find from the myelocyte onwards, there is a secondary granulation that is present. And I'll be finding a neutrophilic myelocyte, a eosinophilic myelocyte, metamyelocyte, etc. So one will be the size. You find the myeloblast is a little smaller than the promyelocyte. And then progressively you find that there is a reduction. There is a depression in the nucleus, and finally a constriction can develop to the multiple segments of the nucleus. This we shall be having in mind. And every time we see a cell, we should try to pin it. Have a kind of a punching machine with you, the cell counter. And the moment you press the button, that means you are confirming yourself about the diagnosis of that particular cell. It is really worth it to be continued. Thank you.